Welcome back to Inside ISAPN, your source for all things APRNs in Illinois. I am your host, Dr. April, and today we're diving into the legislative journey that shaped advanced practice nursing across our state. We've made major strides from initial licensure to full practice authority, and today's conversation is all about how we got here, what it means for your practice, and where we're headed next. I'm joined by someone who has been at the forefront of it all, our ISAPN Executive Director, Susan Swart. Susan has been a powerful voice in healthcare policy, nursing practice, and APRN advocacy for decades. So if you're wondering how APRNs earn the right to sign school physicals, prescribe independently, or practice with full practice authority, this episode is for you. Thank you for being here tonight with me, Susan. Always great to see you.
Thank you very much. I'm looking forward to the conversation.
Okay. So we're just going to get right into it, and we're going to start from the beginning. So our licensure era, which was like 1994 to 2001. Susan, can you take us back to this era? Like, what did that mean for APRNs to go from certification to licensure? And what was the significance of issuing the first APN license at that time, right?
Well, first of all, I just want to recognize that I have spoken to the person who actually did this work before I came on to the picture. And so I just need to do a shout out for the work that Sue Clark did with the leaders of ISAPN from 1994 to 2001, because they laid some amazing groundwork. But essentially, prior to 1999, APRNs, and it was FNPs and PNPs, primarily, were certified by the state, but not licensed. And so what certification essentially meant is it recognized their education, and in some circumstances, for those who were certified, their national board recognition, but it didn't carry any legal authority to practice. And that was the issue. There was a lot of control and a lot of gray areas. So the move to licensure, what it did is it just formally recognized and it established APRNs as licensed healthcare providers under Illinois law. Because prior to that, they were licensed RNs. That was the only license they had.
Mm-hmm.
So the moment that what this essentially did is when this happened, APRNs were no longer operating in what we often refer to as a gray zone, right? It's that regulatory, it doesn't say we can, it doesn't say we can't. And so there was a lot of gray. And it really truly elevated their status within the healthcare systems and really provided a clear signal for both patients and other healthcare providers about the recognition of the competencies that they had. So that first APN license, it was APN license when we first started, not APRN, was issued in 2001. And essentially what it did is it laid the operational groundwork for elevating APRN's authority, your accountability, and even more importantly, at the very beginning, the visibility of what APRNs brought.
Yeah, I know. I tell people all the time, I'm and forever grateful for Sue Clark and the early ISAPN leaders who did this work, because I wouldn't be able to practice how I'm practicing now if they hadn't. So of course, right. Huge shout out to them. Okay, so from 2001, when the first licenses were issued, again, before I was an APRN, there were still some successes that directly impacted practice, such as authority to sign physicals, refer to therapy, and determine disability. How did that play into it with the new licensure now?
Well, essentially what it did is it allowed for access, a tremendous amount of ability to improve access to healthcare. And it did a lot of work on legally defining the scope of practice for APRNs. It allowed for APRNs to more clearly delegate, because I know that APRNs weren't working alone back then, but because there was no language, it wasn't clear who or how they could delegate and whether that those individuals were accepting delegation appropriately. It provided for a broader scope of, yeah, or allowed for prescribing. And it really did recognize APRNs as providers for the first time in a regulatory framework. And using the term regulation all the time, I am sure to make sure that I clarify for people that regulatory framework is what has allowed us to get to where we are. And so the evolution of that foundation of what we've been able to achieve expanded APRN roles. It allowed us to have what we have today. It strengthened that healthcare access issue. And it really has tremendously shaped what we now know to be modern nursing workforce in Illinois, right? When we first started, I mean, we'd always hoped, but I mean, we have over 20,000 licensed APRNs in the state.
Mhm.
So those early expansions are what helped do that. And it really did the Medicaid piece, the reimbursement pieces that we have been successful in chipping away, when it improved the access for those underserved areas for low income. And it also did it incentivized APRNs to accept Medicaid, right? Prior to that, it may have been a choice or their employer's choice if they were, because back then most APRNs were employed by an employer. It incentivized them to accept Medicaid because that reimbursement level was there. It helped individuals in the community to reduce wait times, which was a lot of the conversation back then. And then it just spread out the providers more across the state so that everyone had, I'm going to change the word everyone because I know that not everyone still has access, but it changed the distribution of providers and allowed for more populations to receive care.
And that's the beauty of having APRNs practice too, because we are in those rural areas serving those people who need care the most. Where I would say we're not afraid to go.
Yes,
We're gonna go where nobody else is gonna go most of the time. So
absolutely.
all right. So that was our early practice expansion from 2002-ish to 2006. So then moving into 2007 on, so about 2015, what were those next game-changing policy wins for APRN?
So this is the part where I get really excited because this is the 2007 is just when I started doing policy work. And so I lived this piece. And although I wasn't directly involved with ISAPN in 2007, I was involved in the rewrite of that Nurse Practice Act. So when I was going back and looking at everything, I was like, oh yeah, I remember that conversation. Oh yeah. So so let's talk about it. In the early days, that 2007, 2015, what we managed to do is first, we had much, and I think people forget this, there were a lot more restrictions than what we have been dealing with over the last decade. There was, at the beginning, when you first got Schedule 2 drugs, you could only prescribe 5 and they had to be oral. And then we went a little bit broader in the next one. So the next year, when we went back and introduced legislation, we went to a broader authority, and that allowed us to prescribe more. So it went from Schedule 2, a broader Schedule 2 to Schedule 5. Then we moved into removing barriers. And so we removed joint approval of requirements for orders. When APRNs first started practicing, they had to have written guidelines that they worked on with their collaborator that told them exactly what they had to do. And so we chipped away at that. And essentially those three things together expanded clinical capacity. It, especially in primary care, which was our biggest thing, as well as behavioral health. We moved into being able to address pain management for our patients, and it helped in areas where we were beginning to see more patient need, but also recognizing that there were provider shortages. And then we started working on, in 2011, 2013, and 2015, we started working on eliminating that lovely written collaborative agreement that we all continue to talk about. But I will tell you, there was amazing resistance, right? None of the things that we have been able to achieve have been achieved easily. And it took hours and hours of meetings and discussions and negotiations and ultimate compromise where nobody really walked away with everything that they wanted. But we did get some major wins. Every time we have introduced a bill, we have come away with something. And I will tell you, we should be very proud of that, because that is not the way it happens in many states. So that 2011, 13, and 15 bills, that was where we started chipping away more at the written collaborative agreement requirements and those barriers that we had in place. So those lovely in-person monthly meetings that APRNs used to have with their collaborators went away. We wrote language that specifically said that a written collaborative agreement couldn't limit the types of patients that a person saw, because we were seeing that happen in those written collaborative agreements. And it couldn't define or limit third-party payers. So that was important. It stopped the employers from being able to put in geographic restrictions to practice related to the written collaborative agreement. Our colleagues in Missouri are still facing that. It allowed us to have electronic consultations instead of in person, which was a huge win, because that meant a much broader pool of physicians who could collaborate with APRNs, because we didn't have to have those in-person meetings. You could pick up the phone and collaborate electronically. It talked about temporary practice, which we don't really have to worry about so much. But there was a lot of conversation, or we don't have to worry about so much now, but there was a lot of conversation back then about the fact that if the collaborator left or passed away suddenly, then the APRN who had their own patients was then not able to provide treatment. So we were able to secure temporary practice. So you could practice for 90 days while you were seeking another collaborator. And all of these things really loosened the hold that physicians had on the oversight language. And it was something they held on dearly to. Let me just be honest with you. It also allowed you all to be more mobile, and provided you the opportunity to be more flexible in your practices. And it also included language, things that we talked about legislators. I remember the word we kept saying to legislators about that temporary practice is how important it was for continuity. Like, if all of a sudden your collaborator was gone, was it fair to the patients that that you all were taking care of to just lose their provider? And so that was the opportunity. Then there's always those things that everyone thinks wasn't all that important, but I will tell you, when you add it all up, it impacted people differently according to where they're practiced. So we did a lot of institutional privileging information, both throughout our history, but 2007, specifically 2011 and 2015, we addressed APRNs who work in hospitals and ASTCs. It was during that time period where we finally, it was 2007 when we removed that a written collaborative agreement was not required in order to be credentialed and privileged in a hospital. And I know for some of you out there, you're saying, what? Because that written collaborative agreement kind of got baked into medical bylaws. But it was way back in 2007 that we got rid of that. And then we allowed APRNs to write discharge prescriptions under their own name instead of the physician's name. And all of that was about strengthening the role of APRNs in inpatient setting as well as in surgical care, because as we were doing that for hospitals, we were doing that for ASTCs, which are ambulatory surgery treatment centers. So all of this began to, honestly, when you look back in history, it was at that time that hospitals started recognizing that by removing some of these barriers and getting rid of some of this, it would streamline some of their processes and made having APRNs very attractive in the hospital setting.
So that was significant. And what I definitely want people to realize is that none of that was overnight. That was
Yeah.
8 years.
No, of course.
A lot of work, a lot of time went into all of those years of just, continuous on and on. Just again, I just have to keep saying that thank you for those of you who are doing this work and didn't quit and was like, forget it. Like,
Yes. No, we were relentless. I have to be honest. Sue Clark set that standard, and to the point where there were times, there were deliberate years where we took a year off because we would be so much in the legislators' faces that they were like, please, could you
give me a break.
give us a break? Like, we can't do this, because it was never easy. And it did require a lot of arm twisting and to get everyone to the table. And the Med Society also got a little tired of us. And so, not that we should be worried about that, but in the atmosphere of what we live with in Springfield, you really need someone who's going to be forced to negotiate with you to come to the table in the right frame of mind. Otherwise, you're all just spinning your wheels.
Right. So then from 2015 to 2017, there was a lot of work being done still. So they had a little break. But in 2017, of course, this is like my favorite piece of legislation, when we went and we were able to secure full practice authority win in 2017. Yeah. So walk us through House Bill 313. What did it take to pass, and why was it such a major turning point for APRNs of Illinois?
Well, this is the one where I don't use the word historic very often, but this really was an historic turning point for APRNs for a couple of reasons. First of all, the unity within the APRN and the APRN groups, our CNMs, CNPs, CNSs, and CRNAs, it really took an unprecedented amount of unity and a shared strength, persistence to no end, and compromise to end up where we ended up. So let me just lay out the picture. APRNs came from across the state. We owned the Capitol that year, and we were down there. I think I personally I lived further than Sue Clark. She actually lived in Springfield during legislative session, and I live about 2.5 hours away. And so I had a hotel room for 2 weeks straight while we were in the deep at the end of the session trying to get this done. And we had APRNs signed up every single day. So this was Monday through Thursday in the Capitol. They would take turns showing up so that we could go from legislators' room to legislators' office to continue those conversations. We were extremely organized in our efforts, and it was although there were a lot of individuals there, and I know that you've mentioned this, but we can't forget the years of groundwork that it took, right? Because if we hadn't achieved any of those other things, what we did in 2017 wouldn't have happened, right? So we had built a reputation of honesty, a reputation of being willing to compromise and come to the table with the thought that we weren't just going to walk away with everything. And really did set the stage for what we were able to do. So there was enough legislative support by the time we were at that 2-week stance for legislators to actually consider allowing us to move forward without an agreement with ISMS. And that was a major departure from anything we had ever dealt with before, because prior to that, we were told, go in a room and figure it out. We're not going to get between nursing. We're not going to make a decision between nursing and medicine. So you all figure it out. And when you have an agreement, come back and talk to us. Well, we were doing that. And lawmakers, because of them typically insisting that we negotiate and come to consensus, just prior to that 2 weeks of intensive time that we spent in Springfield, and we were given permission to do this, ISMS was really not engaging with us the way they had in the past. But for whatever reason, that particular year, the political climate kind of shifted, and legislators kind of gave us, when we said we want to try and do this without their support. We want to do this. Actually, the words we used is we want to do this over their opposition. We want to see if we can get enough legislators to pass this bill. And so we began that work, and we were about a week in to that 2-week time frame where we had APRNs there all the time, and that the legislators finally said, all right, enough. And they really did force us to come back to the table, the Med Society to come back to the table. And we negotiated while people were still out there talking, right? Those APRNs were still out there talking. Sue Clark and I and the Med Society and Debbie Broadfield, who was very involved back then as well, we were in very intense negotiations. And I will tell you, we made more concessions. The Med Society made concessions. And essentially what we ended up with was being able to have full practice authority, not the way we initially wrote the bill, but still full practice authority for CNPs, CNMs, and clinical nurse specialists. We call it codifying. So we were able to get that codified in our Nurse Practice Act. It was, go ahead.
I was gonna say, what's really important for those of you listening to note, if you didn't hear this, Susan said there were APRNs signed up at the Capitol, showing up. Like, this is why it's important for us to unify and show up in numbers and show that we are all on the same page. Like, that is strength in numbers, and that's just the support of each other and what we vow to our profession, that we need this. That's just like so important.
Yeah, I think it's the other thing, or in summary of what that ended, because I've spent some time today in preparation for today kind of thinking about what does it mean? I mean, I go out and talk about this. We all talk about this all the time. We're still talking to APRNs about why full practice authority is so important. But from the outside looking in, right? It's important for us, but from the outside looking in, it was the first time where an APRN is able to say that they can practice without a written collaborative agreement. And I know that the term Med Society hates when we say this, but it's about practicing independently. But that's really what it means, is that there wasn't another provider signing a document that said, I'm giving this person permission to practice and to provide healthcare. So it really did define APRNs as autonomous and represented a huge victory over the resistance that the Med Society had brought to the table for years and years. And it really wasn't just a policy change, it was a power shift.
Yes.
And that power shift is still getting momentum. And I know that we're going to be talking about some of the successes that we've had more recently, but that power shift, it was at that point that it became known that Illinois valued and was going to allow for nurses and the nursing workforce to be empowered to do what we know that we're capable of doing.
Yes. And so for those who are listening who may not know, what are the requirements of full practice authority?
Okay, I can do these with my eyes closed, I think. 4,000 hours of practice. Okay, so you get out, you have to have a written collaborative agreement with a physician until you have had 4,000 hours of collaborative practice, right? And then 250 hours of CE or training. And that is very, very important because people tend to think only traditional CE, but the training that you go through when you become employed, I tell people all the time, figure out how you document that, especially those who work in hospitals that have to go through the privileging process. There's always a bunch of hoops you've got to go through. You've got to do so many procedures before you can do it independently and or under supervision. And then once you read, but the hours that it takes for you to get to that point is training. So I always tell people it's so much easier because when we said 250 hours at the beginning, everyone panicked. So 4,000 hours of collaborative practice, 250 hours of CE or training. And then once you have that, you fill out the application. The application comes with a couple of forms. One is a notarized attestation. That attestation is you're attesting to two things. You're attesting to the hours of practice and the CE. The CE hours you sign, the 4,000 hours, your collaborating physician or physicians, if you worked with multiple, sign that agreement. And then there are some caveats around prescribing opioids that include registering with the PMP, putting the collaborating physician's name if you are prescribing Schedule II drugs. It's not collaborating, it's consulting physician for Schedule II drugs and making sure that there's still those monthly conversations that are happening. And that's really the gist of it. It's a lot easier than people think. I don't think, I know, because individuals have reached out to us at ISAPN and told us that some employers tried to dissuade individuals from getting this. And especially at the beginning, I think that that's kind of lessening up now. But it really is. I tell people when their employers tell them, nothing's going to change, don't need to get it. I said, that's fine. You can, but they can't tell you the type of license you have. And you can continue to work with those barriers that exist underneath a collaborative agreement. That's your choice. That's an employment agreement. But that doesn't mean that there's somebody giving you permission to practice because you've earned the right to practice without that permission.
And I tell people, like, anything can happen. You have this job today, this position today. If you lose it tomorrow, I know companies right now are looking for nurse practitioners or APRNs that have full practice authority. they're looking to hire. They don't want to deal with they're like, I need an APRN who already has full practice authority.
Yeah.
So I always tell people, don't wait to get it. I'd rather you get it now. If you don't need it and you have it, then you need it. And now you're scrambling, trying to figure out how to get these papers signed and how to do all this. So,
And we all know that there's nothing easy in IDFPR. So
so
the delays are tremendous.
yeah. So if you're listening to this and you are eligible for full practice authority and don't yet have it, you need to get on it. If you're an ISAPN member and you need help, you can reach out to Susan or I. We will gladly help you get that paperwork done, answer any questions you have, because we need everyone to know that it's your professional duty. We have this license for a reason, and you don't want to be looking for later, I need to get this, and now you don't have it available. Yeah. Great. And so now we're going to move forward to recent progress. So now we're in 21 to 23. Are there any updates between that time that APRNs should be aware about that they may not even have realized yet?
Yeah, but I want and kind of lay out the groundwork of some of the thought processes that ISAPN goes through. I mean, ISAPN, under my tenure, under previous tenure, the leaders before they had an executive director were meticulous about documenting barriers and things that needed to change. And we're having really strategic conversations. So there's been a list at ISAPN of things that we need to do, but you can only do so much, right? Remember the legislators telling us, could you like stop for a little bit? And so between 21 and 23, we took some what we referred to kind of low hanging fruit, but even the low hanging fruit was about policy change that was going to strengthen the APRN's ability to be autonomous. It was about reducing oversight and those structural barriers that had been built in and baked in many pieces of legislation. And it really did allow us to, it wasn't just administrative updates, but really was about continuing our progress at fully recognizing APRNs as primary independent providers in all settings, right? So let's talk about a few of them. And you're right, April. I'm not sure that everyone knows, because I still have APRNs who've been practicing way back who said, when did you get rid of 5?
Right.
And I'm like, we got rid of 5 like a decade ago, right? The 5 medications you could prescribe. But death certificates, we realized that it was ridiculous that an APRN could not pronounce an individual and sign they could pronounce, but they couldn't sign the death certificate. So that was especially important. And we heard a lot from hospice and in long-term care, and a lot of really horrifying stories of unnecessary delays for families in being able to move on, because we had to wait because those, all that postmortem documentation that had to happen before an individual can be released and their family can, make the funeral arrangements, right? We're there. So that was a big one. The other one that we did was for psychiatric mental health nurse practitioners. And I do realize that I forgot that back in 2009 is when we really made progress with psychiatric mental health and provider NPs, and we were able to get them 100% Medicaid reimbursement too, which was a huge piece for us. So that recognition. So we continued that work, and we allowed them to practice in what we call Smurfs. And the first time someone said a Smurf to me, I was like, I have no idea what you're talking about. I just think of Smurfs as those little blue characters that my grandchildren watch on TV. But it's specialized mental health rehabilitation facilities. And so the significance of this is that it really did expand mental health workforce in some really high need areas. and allowed us to have some direct input or impact on recovery-based care models that involved mental health needs and behavioral health needs, and really did allow APRNs to cement themselves with those vulnerable populations. So it was a huge piece. Then moving on, the last one that we handled in that period of time was removing the requirement for APRNs to maintain that standing consulting relationship with physicians about benzodiazepines. Because there have been several times in my career where bills have been negotiated, not just for APRNs, but I can think of one off the top of my head for RNs, where you did it for the right reasons at the time, and then shortly thereafter, they all just kept, like, people came out of the woodwork and was like, what did we do? How, explain to us how this impacted patient care and access. And that restriction that was locked in around benzodiazepines when you all first got full practice authority was one of those. So we were able to go back and provide enough proof and testimony and personal stories about that we were able to change that standing consulting relationships to just a consultant that if you prescribe more than 120 days of benzodiazepines, you have to consult with the physician. It's not a physician that's in the PMP that's your consulting physician for Schedule 2s. And I have heard from our APRN colleagues who are very much treating the mental health and children that and adults who have been on benzodiazepines for a long period of time, that this has meant a tremendous amount to them and allowed them to provide necessary services. So that was really important.
Mm-hmm. And even for me, so the death certificate piece, I do house calls. And so I'm the only one seeing some of these patients during, their transition or their last days of life. And so then when they do transition, thankfully I've never had to be like, I don't know what to do, or I can't sign this death certificate. No one knows this patient. And so that has been a tremendous help for me too. So things like that, this legislation that has moved, and those things that you say low hanging fruit, they mean so much. They help our practice to, again, be independent. So and so during this time also, or I guess all the time, how important is it to align the Nurse Practice Act and the Medical Practice Act?
We learned this the hard way. We have always tried to make sure that when we were updating something in the Nurse Practice Act, that it also got updated in the Medical Practice Act. But we ended up with a particular organization in the central part of the state, a system, reaching out and talking to us about their attorneys advising them that the physician had to have the same practice as the APRN. And I was like, nope, we removed that out of the Practice Act. Nope, I know for sure that's not there anymore. But the problem is they pointed to the Medical Practice Act. So not having harmony between those two statutes caused conflicts of interpretation with attorneys and created barriers to practice. So having that, getting that changed, and then being very, very diligent in every piece of legislation that we have talked about since then, in any piece that we have worked at, it was like one of those lessons learned, because we have to make sure that there's always clarity in law and that there's only one standard that people are looking for, especially when it is two different professions. required to collaborate and work together so that we make sure that that is clear across all disciplines. It is really important for employers and health systems because it allows them to build better processes, and then they also don't have to get attorneys involved, and then we all know how much money that can cost. And I always joke and say that you can talk to 5 attorneys and each one will give you a different opinion. And it's the truth. But it becomes a huge issue. And it becomes about reducing legal risk, because anywhere there is any shade of doubt, it produces a potential for risk. And so APRNs and physicians both, when we worked diligently to make that happen. And this last one, absolutely no pushback from the Med Society whatsoever. The one thing I can say about our negotiation and the relationship with the Med Society is and it's true for us as well. In Springfield, you're only as good as your word, right? So when you go to the table and you negotiate and you have those conversations, you're like chiseling in stone what you're agreeing to, and you can't backtrack. So when we brought it to their attention that this was the interpretation that was happening with a particular system, they were like, okay, let's get this done. And so because they saw that it benefited them, because it allowed for very clear expectations from the physician side of the table of the collaboration, as well as for the APRN. So it is essential, because if there's what I have learned is if there is any doubt, they will err on the side of caution, which will mean more barriers for APRNs.
Mhm. Yeah. So bringing us up to today then, so what are the upcoming legislative issues affecting APRNs that we should be keeping an eye on?
Well, let's see. We are still gathering. The other day, we had a really good meeting with the legislative committee, and wrapping up this year. This year we have done the board and the legislative committee or the GR committee, sorry, not legislative, the GR committee has done a stellar job at focusing on the crisis in maternal health care that we're dealing with. And the board did a lot of background work. I mean, I think we worked on this for about 9 months before it launched. April, isn't that about right?
It was a while. Yeah.
Yeah.
It was, last
A
year.
lot of research, a lot of data and fact finding, and putting together information. So one, APRNs understood what we were trying to do, and then being able to roll that out. And I will tell you that doing it the way we did, we really did back the Med Society, not up in a corner, like in a bad way, but we really laid everything out that they couldn't refute, that there was an issue.
Mm-hmm.
So
what's important is we're increasing access
yep,
to care. We're
absolutely.
people of Illinois. That's what we're doing.
And addressing a need that, I mean, there has been a lot of focus, right? There's been a lot of focus on maternal health care and the disparities that are happening. And we know that hospitals are closing those units, especially in the southern part of the state. Mm-hmm. And so ISAPN really did take something that, was a need, and figured out how the uniqueness of what it means to be an APRN can address those. And we just you all did a great job of just laying out the map, and the legislators are, I think today, it passed the House and the Senate, and today it passed out of the Senate. So it's on its way to the governor's desk, and it'll be law.
Yay. I know I had, this was my third year for nurses at the Capitol only. And sitting in that gallery, hearing our bill, like just it was just such a great experience. Oh my God, it was emotional, it was powerful. It was just so many things all wrapped in one. And I'm like, I can never miss another Nurses Day at the Capitol.
It does become addictive. It
Yeah.
really
I'm like,
does.
oh my God.
My husband's like, sometimes he's like, could you just stop? And I,
No.
because because people call and it is really every single change that you all have managed to do, whether it's, addressing reimbursement, whether it's about prescribing, institutional privileging, all of that. In case those of you who are listening don't realize, every single one of those things that ISAPN has taken on has a ripple effect on our patients, right? So fewer barriers means faster, closer to home care for patients. Expanded scope means providers can provide more care. There's a more continuity, reducing those handoffs. Do you remember like when you had to say to your patient, I can't do that, right?
Yeah.
And you had to send them somewhere else,
Somewhere else. Yep.
right? Medicaid parity, mental health privileges for those underserved communities that we know are so desperate to have services. And then reforming those collaborative agreements and those prescribing, it just really has meant less delays for our patients.
Mhm.
And I think that that's always what ISAPN knew. I will be honest to say to you, I've been with you all now for 12 years. And gosh, it's been 12 years. But I would say in the last 8, the leadership in the last 8 really does understand how, when they're talking about all of these things, yes, it improves your work environment. It improves your ability to provide services. But you've begun to tie it to your patients and the stories and the impacts, and that's really what's made the difference.
Mhm. So we don't have to tell you all why it's important for APRNs to know your scope and stay informed.
Yeah.
All of this information that Susan shared with us is all the reasons why. Even if it doesn't directly affect you, it's affecting someone you know, it's affecting a patient you know, it's affecting somebody in the state. And we need your voice to help make a change. So of course, just not at the bedside either. So we want you in policy. Of course, we need you in the clinical at the bedside, but we also need you to be advocates for your patients, for your communities, and at the policy table, talking to your legislators, because they don't know what we do. So we have to tell them, we have to show up. As Susan said, showing up at the Capitol, showing up in numbers, and just really saying, hey, this is our profession. We love what we do, and we are fighting every day for our patients and our profession, our licenses. It's just the most important thing. All right, so I guess we've already talked about why it's important, how APRNs can stay engaged in advocacy. If you have any other pointers on that, I definitely, of course, joining us, ISAPN, and talking to your legislators. But what else do you have for us?
Yeah. Well, I think sometimes people get overwhelmed, especially when it's something new to them. And it can be as easy as picking up the phone, or as easy as when we send an advocacy alert out, sending an email. And you all know what your capacity is, right? You all understand what your workload is. And sometimes you're going to be able to get more deeply involved, and sometimes you're going to have to take a step back. And that's okay. But what you can't forget is when those things happen and your gut tells you this isn't right? There's something we need to do. We do need you to step up and let others know. Have conversations with your colleagues, share with each other, bring those stories to ISAPN, because we can't help fix what we don't fully understand. And so That's a really important thing. A good example of that is the other night for the government relations in our wrap up. We were like, okay, so what's next? And I said, well, I don't know what's next, right? What's the next thing that ISAPN wants to work on? And so someone just said, well, I know we talked about this last year, but it kind of died, and we had another person talk about it, and we said, well, tell us more about it. And it was around decisional capacity. And so we had this broad conversation about how currently in statute it says that a physician has to determine decisional capacity. And so there's a broader conversation, and it's going to come to the board of directors to see if that's what we need to take on next year. But had an APRN sitting on that committee not been impacted and not seen the impact that it had made on her patients and shared that with us, we wouldn't have known, and we wouldn't have have an idea already about what we could do next year that will improve the lives of not just our patients, but our patients' families. Because when the issue of decisional capacity raises its head, right, it's really hard for the families. And so I just keep telling you all, don't stop sharing. Don't stop talking to each other and then bringing those stories together, because regulation is buried in everything that you do. Everything that you do for patients is governed by regulation, and there's opportunities for us to address that. So get involved at the level that you can get involved, even if it just means picking up the phone and talking to April and saying, hey, I had this happen and I can provide the story, but things are really hectic in my life right now and I can't do any more than that. That's a great thing, right? So I just encourage people to just keep talking.
Yes.
And join ISAPN.
Yes, join ISAPN. Join us. We're a lot of fun here. And as Susan said, when your people are saying, oh, somebody should fix this, somebody should do something, I have to tell you, you are that someone. Your voice matters. We need to hear, we need to know.
Yeah.
All right. So any last minute words of advice, Susan? This was amazing. What an incredible conversation.
No, can you tell I like this stuff a little bit?
A little bit.
It is a lot of fun. It can be tedious, but I am excited, April, because so many people are getting excited about this, right?
Yeah.
I don't feel like the only nerd in the room anymore. I really like that.
I never forget when I first decided to go to nursing at the Capitol 3 years ago. I was like, nervous. I'm like, oh my God, I don't know. What am I going to do? Who am I going to say? And I was like, you know what? I'm just going to be brave and ask somebody to, be my mentor there. And I called Marie Lindsay and I was like, Marie, I've never been. I need to go. Can you help me? And she was like, absolutely. And she took me to that Capitol and we talked to legislators and she was like, they're just like you. What? And the next year I was like, you know what? That was really easy. The next year I was vowed to take people with me. So I took people with me the second year. And that's what it's about, paying it forward. And then this year we had this amazing, powerful thing happen. So it's just been so great. So
I love that story. And I will tell you, Sue Clark used to tell me when I first started doing this work, and she would get in front of nurses and APRNs and talk, and they'd be like, I don't know what to say. And she's like, stop it. You all convince patients, and she uses the NG. She goes, you convince a patient that you're going to put this big long tube down their nose, and you do it. So if you can convince a patient to do those things, you can have a conversation with the legislators sitting at a desk. Right? And I was just like, yeah, because when you think about the conversations we have with our patients every single day and how hard those are, and those are life-changing, right? And you're just talking to a person across the desk. Yeah, what I have learned is they don't know anything about healthcare. Nothing. So you all can go in there. You could all lie through your teeth. Honestly, I I think to myself, you could just make up anything because they don't know
Yeah.
at all. And so you have an opportunity to share with them. And I think that that's the power of it. And I think once you do it, like April said, once you do it, you realize how easy it is.
Yeah.
And every single year, Nurses Day at the Capitol gets bigger and bigger.
Yes, it grows and grows.
And this year, APRN showed up in force.
Definitely, they showed up. Yes,
They did.
Yes.
It was great.
Mhm. Well, thank you for walking us through this legislative journey, of course, that shaped all of our practice in Illinois. For those of you listening, remember, this did not happen overnight, these wins, and we still have work to do. It came from persistence, advocacy, and a collective. So us having that unified voice. And protecting that requires every APRN to stay informed and engaged, and to join ISAPN, stay connected, be the voice of change in the state, in your practice, because we've come a long, long, long way, but there's still stuff to do. So if you're not already a member, now's the time. Your voice matters, and your involvement strengthens the future of our practice. So thank you for tuning in to Inside ISAPN. We'll see you next time where we continue the conversation on APRN leadership, advocacy, and innovation across Illinois.